Good morning. My name is Matthew Bell. I'm one of the breast imagers with Radiology Limited. And this morning I will be discussing imaging the male breast. So to start off with, I want to show you a slide with an outline of the topics that I will be discussing. We will start with gynecomastia and then move on to some of the other common benign entities. We'll spend some time discussing male breast cancer, and then what's the most appropriate imaging workup for patients that are under 25 years versus 25 years and older, and whether or not they have any suspicious clinical findings in any age. Then we'll spend some time looking at screening the high-risk male patient population, and finally screening a transgender patient. So to start off with, we'll look at gynecomastia. Gynecomastia is the most common cause of breast enlargement, pain, and palpable mass in a male breast. It can present unilaterally or bilaterally. And as I discussed with my patients, it's basically related to some sort of hormonal imbalance. There's more estrogen relative to testosterone. This can happen physiologically as a neonate, during puberty with adolescence, and with aging with dropping testosterone levels. There are also other causes, including some well-known medications like antihypertensives, recreational drugs such as marijuana, hormonal changes, which may be related to exogenous hormone therapy, or other underlying medical conditions such as chronic liver disease. And sometimes with gynecomastia, there's no identifiable cause. So a common question and concern is whether or not gynecomastia is a risk factor for breast cancer. And the consensus view at this time is that it is not a risk factor. However, approximately 50% of men with breast cancer may have background gynecomastia. And gynecomastia can present at any age. So let's go through some examples of gynecomastia. This is our standard 4-view mammogram. And we have here the CC or craniocaudal views of the right and left breast, and the MLO or medial lateral oblique views of the right and left breast. There's also a white dot signifying where the patient is feeling a focal abnormality, in this case a lump in the retroareolar region of the left breast. And we see asymmetric increased density, kind of this whitish area behind the nipple. It's more prominent on the left compared to the right, but the patient didn't even know that they have bilateral gynecomastia, as we can see here with the mammogram. This is a typical appearance, sort of a flame-shaped interdigitating or dendritic appearance posteriorly. The patient went on to have an ultrasound over the palpable abnormality of the left breast at the approximate 1 o'clock position. And this shows the fibroglandular tissue as being somewhat darker gray or hypoechoic, and it's interdigitating with the adjacent fat lobules, which is a lighter gray. Up here we have the skin, and back here we have the pectoralis muscle and chest wall. So here's a different patient with more advanced gynecomastia, fairly symmetric, and here is an example of asymmetric gynecomastia. In fact, there's probably no gynecomastia at all here in the left breast. So this patient had a palpable abnormality on the right. And this, again, is a fairly classic appearance to gynecomastia with ultrasound. We can see the interdigitating fibroglandular tissue with the adjacent fat. So gynecomastia can be described as three types. So to start off with, we have acute, and this is also described as florid. This next type over here is more of a chronic or dendritic type. And finally, we have a diffuse type, which looks very similar to a heterogeneously dense mammogram in our female patient population. So again, florid, dendritic, and diffuse. Florid being acute, usually somewhat larger, dendritic, and also somewhat more nodular. Dendritic being more chronic and smaller. We see that typical flame-shaped appearance can also be somewhat nodular. And then the diffuse pattern. And with the diffuse pattern, it's worth asking the patient if they have been taking exogenous estrogen therapy, because that would correlate well with the appearance there on the mammogram. So clinically, your patients may present with either unilateral or a significant number will have bilateral disease. And it may be felt as a lump under the nipple. If so, typically this would be somewhat on the softer side, but could be firm. And it's more likely to be painful than breast cancer, particularly if the patient has had these symptoms for some time, greater than or equal to 6 months. So a very common question is, how is gynecomastia treated? If the underlying cause can be identified, it may be able to, it may be reversed. It may even resolve on its own if it's merely physiologic, particularly in the patients that have physiologic gynecomastia around puberty. If it's related to a medication, and that can be substituted out for a different type of medication, it may resolve. And unfortunately, in some cases, the cause cannot be identified or does not resolve on its own, in which case hormone therapy and or surgery may be considered. So here's another example of gynecomastia, somewhat more advanced than some of the previous cases we looked at. The patient presented with symptoms in the right breast, where we see at least moderate degree of fibroglandular tissue. And there's a milder amount of gynecomastia on the left side. So here we have both ultrasound and MRI images from that same patient. So this is, again, a fairly typical appearance of gynecomastia on ultrasound. And we have two images from a MRI exam that the patient had. This is a contrast enhanced sequence, and this is a T1 weighted sequence, which makes the fat bright. So most of the light white area here is the fat that we can see on the mammogram. On the contrast enhanced sequence, there was no suspicious enhancement, just some mild background enhancement seen. And so there's nothing suspicious to biopsy. So some of the other benign entities that we see commonly in the breast imaging clinic is lipoma, sebaceous and epidermal inclusion cysts, and sequelae of trauma from a fall or car accident, things like hematoma, fat necrosis, oil cysts, and pseudogynecomastia. So there can be breast enlargement without fibroglandular tissue in the subareolar regions, instead just excess fatty tissue deposition, which may be related to an elevated body mass index. So here's an example of a lipoma, and the patient was feeling a lump in the left breast. We have compression views and a marker demonstrating the palpable mass. And we can see in an encapsulated mass, and within the encapsulated mass, there's very similar appearing tissue as the adjacent fat, which makes sense for a lipoma. And this is the ultrasound appearance, very homogeneous encapsulation, and the echogenicity is very similar to adjacent fat. Here's an example of a sebaceous cyst, very commonly seen in the axillary region, but can be seen anywhere in the chest. The cyst is typically within the cyst, but maybe, or excuse me, within the skin, but maybe subdermal and have a tract extending through the skin to the skin surface. Here's an example of a hematoma. There's a fluid level seen on both the mammogram and the ultrasound, depicting the various stages of blood clotting. And here's an example of pseudogynecomastia. There is no suspicious findings, and the patient did present with a palpable lump here in the left breast. And so an ultrasound may not even be necessary in a patient that has a negative mammogram. All right, so let's talk a little bit about male breast cancer. So it's rare amongst the breast cancers, and it's even more rare for it to present bilaterally. When it does present, it's typically in older men, and they typically are presenting with symptoms. And this is because most men are not screened. And so we'll talk about some screening recommendations in a little bit. So what symptoms do they present with? Typically a palpable hard lump, which may be eccentric to the nipple or subareolar. And there may be other concerning signs such as skin or nipple retraction, nipple discharge, especially if it's bloody. These patients are more likely to be at an advanced stage, so there'll be a larger tumor size and a higher chance of metastatic disease to the lymph nodes. So mammography is our main imaging modality for diagnosing male breast cancer. It's great for picking up microcalcifications that wouldn't be seen with the ultrasound or MRI. We can evaluate both breasts, and because there's typically background or fat in male breasts, where there's high sensitivity and specificity for detection of male breast cancer. The sensitivity and specificity numbers are well over 90%. And there's a very high negative predictive value. So if the mammogram is negative for any suspicious findings, we can feel confident that the patient does not have breast cancer. So this is a patient who presented with a palpable abnormality in the left breast. We can see gynecomastia behind the nipple. And then there's also some subtle calcification that is within these red circles here. And the calcification is hard to see, but it's fine, it's linear, it's branching, and it's suspicious for malignancy. And so this went on to be biopsied with the stereotactic guidance, and the pathology results demonstrated atypical ductal hyperplasia. So ductal carcinoma in situ, or DCIS, can also present as microcalcifications like we just saw, or can be more mass-like, as in this case. So the patient presented with a mass in the subareolar region of the right breast. And it's compared to some of the cases of gynecomastia that we looked at, this is more higher density, more mass-like with lobulated borders. And on ultrasound, we see kind of some cystic or ectatic ducts with some thickened septations. So this went to ultrasound guided needle biopsy, and pathology demonstrated ductal carcinoma in situ. Here's an example of invasive breast cancer. Again, as we saw in the last example, this is much more mass-like than gynecomastia, or higher density. We can draw a border around the mass. And on ultrasound, there's a solid mass, which would be suspicious in a male breast. A lot of what we're seeing here is just some shadowing from the adjacent nipple. Here's another case of breast cancer, much larger and more advanced disease. There's nipple retraction, skin thickening, and we see a prominent solid mass on ultrasound. This would be a very typical example of male breast cancer, somewhat eccentric, a little bit removed from the nipple, high density, irregular, and suspicious mass on ultrasound, solid, hypoechoic, jagged borders. So this patient went on to have an ultrasound guided needle biopsy and then an MRI scan to see if there was any other disease, perhaps on the other side, or any nodal involvement, anything else that would be important for clinical management. So this is our contrast enhanced sequence over here. And this darkish area right here is some susceptibility artifact from the biopsy marking clip. The clip is sitting within the enhancing mass. And this is sort of a summation or MIP image demonstrating no suspicious findings in the right breast. In the left breast, there's a color overlay map with predominantly red, which is the type 3 kinetics, or the most suspicious type of kinetics. And this is all consistent with the diagnosis of male breast cancer. Here's another example on the right side, somewhat larger, irregular, high dense, suspicious mass eccentric to the nipple, ultrasound demonstrating similar suspicious findings. So let's talk a little bit about ultrasound. Ultrasound can be helpful for evaluating indeterminate or suspicious findings on mammogram. We can further characterize the mass, and we can guide an ultrasound guided needle biopsy. By itself, the sensitivity and specificity of ultrasound is not quite as robust compared to mammography, but in combination with mammography, there's a strong, very high negative predictive value. So here's a good example of when ultrasound was very useful. So the patient presented with a mass, or palpable lump, I should say, in the left axillary region. And on mammography, there's no suspicious findings seen. This is a compression view. You see the white dot here signifying where the patient's feeling the lump. And we're just seeing some fatty tissue. The abnormality is much better depicted on ultrasound, where we see an irregular, hypoechoic, solid mass suspicious for malignancy. So this went on to be biopsied with ultrasound guidance. And the patient had a CT scan for staging. And here, this is the right side, this is the left side, and this is in the upper chest, looking at the axillary regions. We see the irregular solid mass with the white dot. The white dot is the biopsy marking clip. This patient also had a MRI scan. These are the contrast enhanced images at different levels through the axilla. And here on this slice, we see the enhancing suspicious appearing mass in the left axilla and some adjacent suspicious appearing lymph nodes, just a little bit removed from the biopsy proven carcinoma. So unfortunately, nearly 50% of patients with male breast cancer will have axillary nodal involvement. And a very suspicious sign clinically would be if the patient presented with a nipple discharge. upwards of 50% of patients presenting with this symptom have male breast cancer. So here's an example of a patient who has a suspicious mass in the right breast, as well as a suspicious appearing lymph node in the right axilla. So this is the mass in the breast as seen on ultrasound. And images of the right axilla demonstrate an irregular lymph node with a thickened cortex. So let's spend some time discussing the imaging workup of a palpable lump. So to start off with, this would be a palpable lump with no suspicious features. So suspicious features would be an eccentric breast mass, centric to the nipple discharge or retraction, or axillary adenopathy. And if the patient is less than 25 with no suspicious clinical findings, there's an extremely low likelihood of breast cancer. So we would start off with targeted ultrasound and consider doing a diagnostic mammogram. Perhaps there's something that's unclear with the ultrasound, maybe atypical gynecomastia, or maybe there's an oil cyst that would be better diagnosed with mammography. If there are unresolved suspicious findings with the imaging, then we would likely go on to recommend a ultrasound guided needle biopsy. If the patient is 25 years or older, again with no suspicious clinical findings, then we would start with a diagnostic mammogram and consider targeted ultrasound. As we saw earlier, perhaps it's just merely pseudo gynecomastia or something else that's benign. But if there's any doubt, we can certainly do a targeted ultrasound. And if there are suspicious findings, then recommend an ultrasound guided needle biopsy. So on the other hand, if there is suspicious clinical finding or combination of findings in a male patient of any age, then we definitely want to start with the diagnostic mammogram and probably do a targeted ultrasound. Again, just to review, the suspicious findings would be palpable breast mass, particularly if it's hard and eccentric to the nipple, axillary adenopathy, or if there's nipple discharge and or retraction. If there are suspicious imaging findings, then probably an ultrasound guided needle biopsy. As we saw before, sometimes we'll see microcalcifications that need to be addressed stereotactically if we don't see a corresponding abnormality on ultrasound. So ideally, we would be seeing high-risk male patients as in the screening pool and not when they present with symptoms. So what is a high-risk male patient? A high-risk male patient is one particularly who has a personal history of breast cancer or a strong family history, especially first degree, mother, sister, daughter of having breast cancer, genetic mutations like BRCA2 or Ashkenazi ancestry. So if we can catch cancer early, there's going to be an improved prognosis, likely much lower stage, negative nodes, and we'll catch it hopefully before it's clinically occult. And one study demonstrated a significant pickup of early breast cancer, particularly when compared to women. And again, this is largely because most men have almost entirely fatty breasts. So if you have a high-risk male patient, starting at age 35, we would recommend annual clinical breast exams. And then I would also consider screening with mammography, at least at age 50, perhaps earlier. If the patient has a known family member diagnosed with breast cancer, we could start screening 10 years prior to the age of that family member when they were diagnosed. And a screening order is perfectly acceptable if there are no symptoms. And then you can consider either just a baseline if there's absolutely nothing suspicious on the mammogram, or if there's background gynecomastia, it may be worth doing annual screening if they're high risk, so that subtle masses can be detected earlier than later. All right, so we're just about done. I just want to spend a little bit of time discussing transgender patients. So a transgender man is a patient who was assigned female sex at birth and identifies as with the male gender. A transgender woman is a patient who was assigned male sex at birth and identifies with a female gender. So let's start with a transgender man. So many transgender men will have had a mastectomy, and if they are not at high risk, then no screening is probably necessary. Alternatively, if they are high risk, consider annual MRI screening or ultrasound if they have focal symptoms. On the other hand, if the patient has only had breast reduction, so there's still substantial breast tissue left, or has not had any surgery at all, then I would recommend that breast screening guidelines for non-transgender women be followed. So screening a transgender woman. So some of the things to think about would be, does your patient take exogenous female hormones? And if so, for how long? And are they at high risk? Again, personal history, family history, genetic mutations, and so on. The recommendation would be to follow the breast screening guidelines for non-transgender women, or alternatively, starting at age 50, particularly if they've had 5 years of hormonal therapy or more. And screening mammogram could be either annual or every 2 years. So these recommendations, there's no great consensus. And so these are just some recommendations and considerations to mull over. All right, well, that concludes my lecture. At this time, I'm happy to answer any questions. Thank you.